such clinical scenario in our clinical practice. And this is focused mainly on residents. We have been doing this masterclass for almost 8 weeks since now. And we have discussed earlier 7 cases on different clinical issues. Today also, we are going to discuss an relevant issue, which is how do you approach patient with dysphagia? How do you make a clinical diagnosis? How do you make a difference in diagnosis? How do you plan a treatment? And how do you treat the patient, treatment? As we know, dysphagia is caused by a number of issues. So today we'll discuss one of the very important causes of dysphagia in our patients. For that, we have a wonderful panel of to discuss this case. Among the panel, we have Dr. Uday Ghosal. Uday Ghosal is a professor. Now he's become head of gastroenterology at SGPGI Lucknow. We are all aware his interest in GI functional diseases and also motor disorders. And he's one of the panelists today. Then we have Dr. Sobhna Bhatia. Sobhna Bhatia has been head of gastroenterology at KEM, but presently she is at Sir N.H. Reliance Foundation Hospital in Mumbai. Again, very very great teacher, and she is one of the teachers which has a high value. We have a Dr. A.S. Puri. A.S. Puri had been at G.V. Pant Hospital, presently at Vedanta Medicity in Gurgaon. Again, he is one of the great teachers we have in our country. We also have Dr. Ajay Jain. Ajay Jain is a head of Department of Gastroenterology at Choitram Hospital in Indore. Again, one of the important teachers for our country. To facilitate this panel discussion on dysphagia, Ansuman Helens, he's assistant professor of gastroenterology at SGPJ. He will facilitate this panel discussion. He's one of the bright leaders, young leader coming up in the field of gastroenterology. So with this, let me invite Dr. Uday Ghosal to introduce the two trainees who are going to discuss the case with us today. And then I'll hand over this panel discussion to all the panelists to take over and take us through cases. You can write your questions if you have any, and we'll respond to as many questions as possible. Also, we'll have a number of poll questions, so please do respond to them. Looking forward to a great panel discussion and learning experience on dysphagia. Over to the panelists, please.
Yes. Thank you, Gobind, for the nice introduction. Now we have 2 DM residents. Both of them are from Department of Gastroenterology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Dr. Piyush would be presenting the history and examination of the patient, and subsequently the further detail on investigations and the management will be presented by Dr. Gangadhar Rao. So I'll request Piyush to start the case history.
Yeah. Good morning, all the eminent faculty members. I'll be presenting the history and examination part of the approach to a case of dysphagia. Yeah, my patient, Mrs. XYZ, a 40-year female, housewife, resident of Kanpur, without any comorbidity or addiction. Next, please. Presented with chief complaints of difficulty in swallowing since last 1 year, regurgitation of food since last 4 months. Next, please. Now, coming to the first symptom, that is difficulty in swallowing. It is gradual onset and progressively increasing difficulty in swallowing since last 1 year. It was to both solids and liquids since the onset, and initially occurred approximately 3 to 4 times per week. But since last 4 months, it is occurring with each meal. The difficulty is more pronounced with intake of extremely hot liquids, although she did not complain any correlation to cold food. It was occasionally relieved with upright and bending backward posture. and it was also associated with nocturnal drooling of saliva since last 1 month. Next, please. The patient, though denied any history of difficulty in initiating the swallow, any nasal intonation of voice, dysarthria, diplopia, or dysphonia, any hoarseness of voice, sore throat, coughing, wheeze, or history of recurrent chest infections. She also denied any history of frequent fall, difficulty in climbing stairs or lifting heavy objects, any muscle twitches or fasciculation, any progressive weakness, fatigability, or drooping of eyelid with activity, or any history of Raynaud's phenomena or dryness of mouth and eyes. Also, there is no history of any odynophagia or any food bolus infection, halitosis, heartburn, or dyspepsia. Now, coming to the second symptom, that is regurgitation. Regurgitation, she complains of regurgitation of undigested or partially digested food since last 4 months. It occurs approximately 30 to 60 minutes after each meal, and it was also associated with nocturnal episodes of regurgitation in the form of pooling of secretions over the pillow. It was not preceded by any retching or vomiting. Next, please. She also complains of weight loss of approximately 12 kgs over last 1 year, although her appetite is preserved. Patient denied any history of chest pain, back pain, or squeezing sensation in the chest, any history of past radiation, surgery, or any focal neurological deficit, any history of atopy, allergic rhinitis, or asthma, any history of travel to Latin America, or any corrosive intake. There is no significant family history and no past history of any long-term drug intake. Next, please. There is no history of any comorbidity, addiction, and all the bowel bladder habits are normal. She is vegetarian by diet and her appetite is well preserved. Her menstrual history is unremarkable, but she complains of disturbed sleep due to nocturnal awakening because of the regurgitation. Now, coming to the symptom analysis, her first complaint was dysphagia. Since the dysphagia was not associated with difficulty in initiating a swallow, not associated with any features of other cranial involvement like nasal regurgitation, any dysphonia, any complaint of dysarthria. So my first possibility will be a dysphagia of esophageal origin. Now, since the dysphagia was to both solid and liquid since the onset, and there are also a variation in response of dysphagia to the extremes of temperature as well as posture. So my first possibility will be motor dysphagia. Coming to the regurgitation, since the regurgitation was also not associated with initiating the swallow, it occurring after the patient has taken the meal, so it most likely to be a esophageal origin.
Request the faculty members to help the discussants dissect out the symptoms on basis of history.
So actually, Piyush, thanks for the nice history. But what I'm saying is, would you like to elaborate on all the points for the benefit of the people who are listening, that how to differentiate motor versus mechanical dysphagia? If you do not sort of wish to do so, one of us can do, even I can do. We agree with you that this is not transfer dysphagia, because the patient did not have any problem in initiating the swallow or pushing the bolus to the pharynx. There was no nasal regurgitation or nasal intonation of the voice. And also patient does not have that setting of neurological illness, which is associated with the transfer dysphagia. So that we agree, but we have to now come that if it is esophageal dysphagia, is it motor or is it mechanical? Obviously mechanical, the classic example is cancer esophagus, whereas motor classic example is achalasia cardia.
Yes, sir. So, sir, main differentiating features between the motor and mechanical dysphagia are: the mechanical dysphagia, generally patient complains of difficulty to solids initially, and later on when it progresses, then there comes a difficulty to swallowing liquids also. While in cases of motor dysphagia, the difficulty to both solid and liquid is since the onset of the dysphagia. Patients with Motor dysphagia also may complain of increasing difficulty when they start taking food at the extremes of temperature, like very hot or very cold foods. They also complain of slight relief in their dysphagia with certain postures which they acquire so as to relieve their dysphagia, like some patients get relief with standing upright or bending backward posture. Patients with motor dysphagia complain more of regurgitation as well as chest pain as compared to mechanical dysphagias. Generally, the motor dysphagias are benign onset, so they have a long duration of history, while mechanical dysphagias have a very short duration of history.
Piyush, can I come in?
Yes, sir.
The differentiation between mechanical and motor is it airtight? And would you like to talk about at this stage about pseudoachalasia or secondary achalasia?
Yes, sir. Sir, pseudoachalasia also patients may present with the symptoms like motor dysphagia, and it is very difficult just on the basis of symptoms only to differentiate clearly between the pseudoachalasia and achalasia. We can just predict that there is a more predominance towards the motor dysphagia on the basis of this history.
What important point in history would you take that would differentiate between pseudoachalasia versus true achalasia?
Sir, pseudoachalasia patients generally are due to the malignant disorders, so they have a very short duration of history, sir.
That may not be true. That depends whether it is a very aggressive tumor or not.
And sir, the weight loss also will be predominantly in pseudoachalasia, sir.
Yeah, so you are right. You are right. In fact, there are three typical features. One is short duration, typically less than 6 months, weight loss more than 10 kg, and third is old age. Now, in this patient, we had a very marked weight loss, 12 kg weight loss, but the duration is long and her age is not that much. Like typically old age means more than 50, something like that. So therefore, you have one feature, not the other feature.
Uday, another point is the appetite is not maintained in pseudoachalasia, where the patient will lose his appetite. Here, the patient is clearly having a good appetite and yet losing weight. So if the patient also has loss of appetite, that might be a clue. But otherwise, sometimes it can be very difficult to distinguish. And it's not necessarily old age. You know, you can get in the 40s, so it is not carcinoma esophagus presenting as pseudoachalasia is not unknown. It's rare, distinctly uncommon, but very much reported in literature.
Yeah, that's right. So actually, when we say this is a general rule, but there could be an exception. Now, just if you want me to recapitulate differences between motor and mechanical, the motor dysphagia may be intermittent. Mechanical dysphagia is progressive. As you say, motor dysphagia will have dysphagia to both solid and liquid since the onset, because the motor coordination is required more with liquid intake than with solid intake, whereas in mechanical initially to solid and later maybe to the liquid. Food's temperature with extremes of temperature such as cold and hot, motor may have problem. There is no relationship in mechanical. Relation with posture, in motor dysphagia patient, typically they raise their arm, they straighten their back, and that gives relief to their dysphagia because the esophagus, dilated esophagus is compressed between the manubrium sterni and the vertebra in the back, and that increases intraesophageal pressure. Therefore, it allows the food to be pushed into the stomach in motor dysphagia patient. Usually, motor dysphagia is a long duration, whereas malignancy may be short in mechanical. Episodic esophageal pain is highly suggestive of motor, but not with mechanical. Regurgitation is very suggestive of motor, not mechanical. And weight loss is minimum or none with mechanical, motor, whereas marked in mechanical due to cancer esophagus particularly. So this is just to recapitulate.
But in the Eckhart score, weight loss is given weightage. So one of the criteria for Eckhart score is the weight loss. So it's not
Right,
that
so-
weight loss.
So Pius is going to discuss about Eckhart score later. The Eckhart scores ask you how much is the weight loss, and typically the upper cutoff is more than 5 kg, but you can get in some mechanical dysphagia patient even 15 kg, 20 kg weight loss. So Pius, can you go further?
Next, please.
So I would ask Dr. Piyush to summarize his findings.
Yes, sir. Next, please. So it is a middle-aged female with gradual onset intermittent dysphagia with increasing severity, with regurgitation, with significant weight loss, but preserved appetite without any comorbidity.
So before we discuss the differentials of the differentials made by Dr. Piyush, we have a few audience poll questions so that we have some audience engagement. So I would request Dinesh ji to run the poll for the question which is being displayed. At which of the following diameters of esophagus is a patient able to swallow normal diet without dysphagia? A 18 millimeters, B 15 millimeter, C 13 millimeter, and D 10 millimeter. So Dinesh ji, can we run the poll? So all of you can participate. We'll be putting up the results in a short while. So the results are accumulating, and close to 100 people have answered, but the results look very interesting. So majority of people, close to 70%, have voted 13 millimeter. So let's see. What is the answer? So the answer is 18 millimeter. I would like the faculty to throw some light on the topic.
Dr. Anshuman,
Sir.
I just request the student that they should have, if they are in the endoscopy room very carefully, they should know that most of the time when we dilate the esophagus, we dilate it to more than 15 millimeters. So if they have, and after that the patient do not have dysphagia. So giving an answer of 13 millimeters, they should have applied a little common sense, and more than 15 millimeters should have been in the answer. So you rightly said it's an 18 millimeter, but my only observation is that while you are attending your endoscopy postings and other thing, you should be a little careful. Why are we dilating to 15 millimeter or 16 millimeter in our routine esophageal dilatation, be it a malignant or be it a benign structure?
Very, very true, sir.
So that I think, Anshuman, the reason that people have answered 13 millimeters is because of the original description by Shatsky, that intermittent dysphagia for solids occurs when the diameter of the esophagus is less than 12. And therefore, for them, 13 millimeters is the cutoff for developing dysphagia. And that may be the reason why they've confidently, 72% have answered it as 13 millimeters. So this original description came because that was the cutoff that Shatsky had given. But if you want absolutely no dysphagia, and for normal solids, then 18 millimeters is the actual right answer.
Yeah, actually what Dr. Somnath said is very good clarification. What happens is also look at the question what Anshuman found. He said, what is the diameter of the esophagus in patient able to swallow normal? He is not asking what is the diameter below which dysphagia occur. And in any biological situation, there is a compensation. For your normal swallow, you need a normal esophagus, which is 18 millimeter or more. In fact, side to side diameter of esophagus is 3 centimeter. And anteroposterior diameter of the esophagus is 19 millimeter according to Schlesinger. Now, what happens is that when somebody has a narrowing little below 18 millimeter, they tend to chew too much. By chewing, they compensate so that they don't have dysphagia, and they don't report you have dysphagia. But if somebody is a good observer, will note that he is nowadays taking longer time to eat. Okay, go ahead.
So we have the next poll question. What is the normal resting lower esophageal sphincter pressure? So the options are displayed on the screen. I would request Dinesh ji to please run the poll. So we'll be ready with the results in a short while. So again, the results look very interesting.
Oh my God.
So in fact, the majority of people have voted for 5 to 15 millimeter of mercury. So the correct answer is 15 to 35 millimeter of mercury. So I would request the faculty members to throw some light for the audience.
You see,
So,
yeah, please, Dr. Sumar.
yeah, so the reason that you need some degree of pressure at the lower esophageal sphincter is that you want to avoid, you want to do two things. One is you want to enable swallowing so that the sphincter opens and allows the passage of bolus. And the other thing is you're preventing reflux. So whenever there is gastric activity at the time of digestion or immediately after eating, you see the stomach has to churn the food in order to break it into small pieces. And the gastric pressure at that time is very high. And that is the time that you need a little higher esophageal LAS pressure so that the food does not reflux into the esophagus. So that prevention of the gastric backflow is the pressure is required at 15 to 35. At less than 10, the people actually develop chronic reflux. And at that time, they require chronic therapy. And if it is less than 15, they may have reflux. So higher pressure is required to prevent reflux. For swallowing, any pressure is fine as long as the LES opens up. And we are looking at baseline pressures. So resting pressure, correct? So
Yes.
this is the importance of a little higher pressure. More than 35, if the LES does not relax, then in that case, the patient may develop dysphagia.
So this is very important. In fact, if you read gastroesophageal reflux disease, it writes that anybody who has less than 10 millimeter of mercury LES pressure has a worse prognosis. And if somebody has less than 6 millimeter of mercury resting LES pressure, these people will be on lifelong high dose PPI. So when you gave this answer of 5 to 15 or 5 to 35, whatever, I don't remember what was the answer, majority gave 5 to 15. So that is obviously very low pressure. Earlier, the upper cutoff limit of LES pressure using conventional manometry was 40 millimeter of mercury. Now, according to Chicago high resolution manometry, Chicago 4, it is 35 instead of 40. So remember this figure, 35 on the upper side and around 15 on the lower side. Below 10 is really low.
Yeah. In fact, Uday, you rightly said that patients who have a pressure less than 6 are likely to go on chronic long-term PPI. It's also said that people who have less than 6 and have a very bad quality of life may need surgery for their gastroesophageal. So therefore, a very low pressure is not good for reflux. So can we move on to the next section? Yes.
Yes, ma'am. So we have another question. Which of the following is the most common esophageal motility disorder presenting as dysphagia in India? So Dinesh ji, can we please run the poll? We'll be ready with the results in a short while. So in fact, majority of the people have voted for ineffective esophageal motility. So you will be surprised to see the result. So In fact, the answer is achalasia cardia. In the pre-Chicago era,
Can
we
you
have
remove
only
the
one study.
poll? Can you remove the box with poll?
You can remove it from your own screen, Uday.
Okay, okay.
Yeah.
Okay.
So, yes, Anshuman. Yeah.
So in the pre-Chicago era, we had only one study from SGPGI in which majority of people with presenting with dysphagia, achalasia cardia was the most common motility disorder. Post-Chicago era, we have 3 studies. One from Dr. Jain's center at Choitram. It was a multi-center study in which again achalasia cardia was the most common. One from Dr. Puri's center, Medanta, when again in which achalasia cardia was the common. The only discordant result was from DMC Ludhiana, in which study they quoted ineffective esophageal motility to be the most common disorder. But they had included patients with dysphagia as well as non-cardiac chest pain. So that might be the reason. So I would request the faculty members to throw some light on this.
So, Anshuman, let me tell you that the referral bias is one of the reasons why these kind of results will occur. If you take the general population where gastroesophageal reflux is a lot more common than achalasia, patients with severe reflux will have more dysphagia, or rather more patients with severe reflux will have dysphagia than the number of achalasia patients referred to you. And if you have a center where there is a lot of achalasia treatment being advertised, like very high, what do you call it, the patients where their achalasia poem is going on, and poem has been advertised as a treatment for achalasia, in that case, patients of achalasia will tend to migrate to that center or being referred to that center. So therefore, though these studies tell us that yes, achalasia is not as common a cause of dysphagia, is as common as the other causes, still it will really depend on the referral bias. Now, patients who have dysphagia every day are more likely to go to a doctor and say, sort my dysphagia out. Patients who have intermittent or mild dysphagia, that is those who have gastroesophageal reflux and are likely to have dysphagia, are the ones who do not frequently talk about their dysphagia. And that is also one, they will not undergo more tests for diagnosis as compared to those who have daily dysphagia and those who expect an answer for their dysphagia. So I think, Uday, since you have done one study, you can take it up.
Yeah, so actually is the audio fine? Because Dr. Gobind wrote that there is a problem with audio. Now, Gobind, can you hear me now?
I just wrote a message from Sachin that there's a problem with audio. So
no, now is the audio okay?
I think
Yes, sir, you're audible.
No,
so maybe some issue in individual sort of faculty member. So what?
I have
thank you for drawing this attention. So if you go to the community and ask people whether they have dysphagia or not, and then start doing manometry, maybe ineffective esophageal motility may be commoner.
Yes.
But the question that Dr. Anshuman raised was very interesting. The question was patient presenting with dysphagia in Indian centers. So it is not a question for the community. In fact, we do not have any data from community. Nobody did esophageal manometry in community setting. So your answer should have been achalasia, because his question was those presenting with dysphagia. In fact, if you look at our center data, we did not publish that, where we talk about every patient who comes for motility study, the achalasia will be less common. But we are talking about those who present with dysphagia, their achalasia is common. So maybe go ahead further, Dr. Anshuman.
Sir, so we'll take up the last poll question before we discuss the differential. Which of the following is not a component of Eckhart score? So the options are visible on the screen. So we have the poll running. So I think most of the residents are aware of this.
yes.
Okay, Jan, can you keep yourself mute if you're not speaking?
So as correctly pointed out by the majority, 85%, need to modify diet or posture is not a component of the Eckhart score. And in fact, it is part of the achalasia quality of life questionnaire, but not for of the original Eckhart score, which was described in 1992 by Eckhart. So if any faculty member would like to throw some light on Eckhart score, so that after that we can proceed.
This is very important, Eckhart score. So whenever you present a patient of motor dysphagia or achalasia, please use the Eckhart score. Now, there were some audience question or participant question related to this. Somebody asked that this patient had progressive dysphagia. See, the progressive dysphagia typically means the patient has dysphagia to solid initially. As Dr. Ansuman said, when diameter of esophagus is normal, that is more than 18 millimeter, no dysphagia. There is a borderline zone of 15 to 18 where patient may chew a lot and may take little help of water and then swallow and may not report dysphagia. Below 15, they will have dysphagia to solid food. When the diameter comes below 10 millimeter of mercury, they will have dysphagia to liquid food as well. And this is what is called absolute dysphagia. Question is, this narrowing of the esophagus will take time. It will be step by step in a progressive manner. Look at our patient. Our patient started having dysphagia to solid and liquid both. That's why in achalasia, you typically ask that of all the swallow, in what percentage of swallow do you have dysphagia? So it may be occasional or it may be to all swallows. Second is another person asked, why is there relation with temperature of the food, cold and hot? In fact, our patient had more dysphagia with hot food, which is very interesting. It happens more often with cold food, they have dysphagia, because you all know that motor system and sensory system are in problem in achalasia. Therefore, we all know that it is the cold which give more sensory stimulus. That's why they have typically more dysphagia to cold food rather than normal temperature food. So Eckhart score talks about that weight loss, dysphagia, retrosternal pain, and regurgitation. And you can see in our patient, weight loss was 12 kg, so it is more than 10, so it will give you 3. Dysphagia patient had to each meal, so it will again give you 3. Retrosternal pain was there, not there in this patient, so obviously it becomes 0, and regurgitation was there practically to each meal, so therefore it will be 9, Eckhart score of 9. So this is what it means.
So I would request Dr. Piyush to present his differential diagnosis based on the history.
Ansuman, can I ask one question? The question, can you tell us more about Eckhart score 9, as you discussed? It has some relevance in the making a diagnosis, or just on follow-up that Eckhart score is 9 and on treatment it has come down to normal
Yeah,
or level concept.
That's right. So actually, typically, when you are grading Eckhart score, it is not important in the diagnosis, truly speaking, because diagnosis, gold standard of achalasia diagnosis or motor dysphagia diagnosis is esophageal manometry. But you know how severe the symptoms, how severe are the symptoms of the patient. Second, on follow-up, on dilatation, after dilatation, you want to see whether Eckhart score was reduced and how much it was reduced. Let us say Eckhart score comes down to below 3. That basically means that the patient has improved remarkably. On the other hand, you have dilated and Eckhart score still remain 6 or 8. You know you have done inadequate dilation. So it is particularly for assessment of prognosis or assessment of outcome. Second is also to match different patient or compare different patient, their symptom severity. It is not for the diagnosis.
Okay.
So Dr. Piyush, would you like to present your differential?
Yes, sir. So with all this possible clinical history, my syndromic diagnosis will be esophageal motor dysphagia. I've already enumerated the differences between oropharyngeal, esophageal, and motor versus mechanical dysphagia. And the differential diagnosis, since the patient most commonly present with symptoms of dysphagia and regurgitation, which are the most common symptoms in achalasia. And also, as Dr. Anshuman already showed, that this is the most common disorder which is presenting to the referral centers. So my first differential will be achalasia cardia. followed by the next manometric finding of differentiation, which can be differentiated only on the basis of manometry, ineffective esophageal motility, esophagogastric junction outflow obstruction. And since the patient is also having a significant weight loss of 12 kg, so I will still keep a pseudo-achalasia also a last possibility.
Dr. Piyush, can I ask you a question?
Yes, sir.
How common is regurgitation in ineffective esophageal motility?
So basically ineffective esophageal motility patients present with dysphagia. In patients who present with dysphagia, ineffective esophageal motility is found in 42% of cases. But in those patients who have regurgitation, they also have 42% of cases presented with ineffective esophageal motility. That was
in fact, very important question that Dr. Jain asked. Ineffective esophageal motility is often associated with severe GERD. Dr. Sobna already mentioned to you. So ineffective esophageal motility is often associated with severe GERD. And we all know regurgitation is an important symptom, particularly in severe GERD. Therefore, regurgitation is not uncommon. But one thing is important, ineffective esophageal motility patient often will have heartburn. This patient, interestingly, did not have heartburn. Now, you see, therefore, I would tend to say ineffective esophageal motility should be lower down because regurgitation we can agree. We can agree dysphagia can occur in ineffective esophageal motility, but there is no this thing, heartburn. If you ask me, can achalasia patient have heartburn? Yes, 20 to 30% patient of achalasia patient can report heartburn in absence of any gastroesophageal reflux disease. In fact, gastroesophageal reflux disease is very uncommon in untreated achalasia because ALES is tight. So how will the gastric content reflux into the esophagus? But this is called motor heartburn because there is a motor disorder, the dysmotility, the spasm may be interpreted by patient as heartburn, but this occurs only in 20 to 30% patient. But severe GERD, more than 80 to 90% will have heartburn. Those, therefore, I will put ineffective esophageal motility much lower down. Dr. Sobna, your any comment on this from your side because you are expert on this.
So Dr. Uday, thank you. I think you put the point across. Now, the reason why these people have heartburn when there is an obstruction at the lower end is that there is a lot of food which is accumulated there. And because of stasis of food, there is fermentation and the pH of that food tends to come down because of fermentation. And therefore, heartburn may be experienced. But what is very important is that the history of regurgitation should always be taken in more detail. When we ask these patients, they never have sour regurgitation. They have bland regurgitation. Patients who have sour regurgitation because of acid in the esophagus are more likely to have reflux, whereas people who have bland regurgitation can occur in two situations. One is where there is a motility disorder, and second, where the patient has already received a lot of PPIs, and therefore the regurgitation or the volume reflux continues to be bland. So the history taking is very important in this case. And Piyush, you want to say something about this history? That you asked for sour versus bland regurgitation in this patient?
Yes, sir. I specifically asked, sir, ma'am, though she told that the regurgitation was bland, it was mostly containing the undigested food particle.
Okay.
Yeah, Piyush, so what I was trying to tell you is that absence of retrosternal heartburn and chest pain, I think I would have put an ineffective esophageal motility much lower down in comparison to achalasia, diffuse esophageal spasm, and outflow obstruction. That's what I was trying to make a point.
The same thing, like even diffuse esophageal spasm is often associated with chest pain. And the chest pain can be quite severe in these people. So EGJ outflow obstruction might come higher, and ineffective and esophageal motility and diffuse spasm might come lower. In fact, pseudoachalasia might come a little higher than that. Okay.
Can I ask one other question here?
Yes.
Just to complete the symptomatology and its interpretation, would you consider, because since the regurgitation, any kind of esophageal diverticulum in such patients, It may not be common, but would you recommend that we should consider diverticulum as one of the differentials?
Let Piyush first answer and then the faculty can take up. Piyush, would you like to consider an esophageal diverticulum in this patient as one of your differential diagnosis?
Yes, sir. Generally, the patients with esophageal diverticulum, mostly the Zenker's diverticulum, they present like oropharyngeal dysphagia, and the difficulty starts since the onset. And mostly such kind of patients will also complain of halitosis also. Halitosis and regurgitation immediately.
Any other important thing? Any other important thing other than
Yeah.
halitosis?
Yeah, please, go ahead.
Piyush?
Now, as Pius mentioned, that diverticulum are of three types. One is a Junker's diverticulum. This is an upper esophageal diverticulum. There is a mid-esophageal diverticulum, which is a traction diverticulum. And third is a pulsant diverticulum, which happens in the lower esophagus. So just understand the differences between the three. The upper esophageal diverticulum is a congenital problem. The traction diverticulum occurs because of lung scarring, and therefore it is pulling the esophagus. And pulsant diverticulum is because of increased intraluminal pressure in the esophagus. Therefore, there is an outpouching above ileus. Now we are considering a possibility of achalasia here, and in achalasia you can have a pulsant diverticulum that only barium will tell us, or time barium will tell us. That I don't know now. There could be associated pulsant diverticulum. As Pius suggested, Zenker's diverticulum is less of a possibility because of all the things we mentioned. In addition, I don't expect so much dysphagia in Zenker's diverticula, even if there is some dysphagia because the diverticula is full and therefore it is compressing on the esophagus. But this sort of a progressive symptom over 1 year with relation with temperature of the food and all those is not expected in Zenker's diverticula.
So to summarize what Professor Uday has said, Zenker's diverticulum presenting as dysphagia is most of the time is very intermittent with absolutely normal phases in between. And here's this patient who has a symptom almost on a daily basis. So we will not consider that possibility even in our differential diagnosis. Am I right, sir?
Yes.
Yes.
Okay. So Piyush, will you consider a dysphagia lusoria as a differential in this case?
Before you say whether you consider or not for the participant, Dr. Pius, can you tell what is dysphagia lusoria?
Yes.
Dysphagia lusoria is due to the extrinsic compression of the esophagus due to the aberrant origin of right subclavian artery.
Yes. So will you consider it in this case, given the history of intermittent dysphagia in a 40-year-old lady? So we are completing the list of causes of motor dysphagia and mechanical dysphagia here. So that is the reason this question has been asked.
Yes.
So would you consider it, not consider it?
Pius, can I ask you, is dysphagia lusoria a motor dysphagia or mechanical dysphagia?
It's a mechanical dysphagia.
Mechanical dysphagia. Very good. So,
Good.
so this is some of the disorders of mechanical dysphagia can actually trick you into thinking that it is a motor dysphagia. The dysphagia is intermittent. It may be for solids more than liquids. So, and therefore you might be tricked into thinking that it is a motor dysphagia, and there is no weight loss. It's not progressive. So therefore this differential should at least cross your mind even if you do not put it down. Okay.
So, sir, we often as residents had difficulty differentiating regurgitation, reflux, and rumination. So if that difference can be brought out here for the benefit of the residents.
Yeah,
And
let
Piyush,
me tell you. Yeah, please, Dr. Sob.
And Piyush first try to answer that, sitting as the candidate for about 1 minute, and then maybe you can take over. Yes, Piyush?
Regurgitation is basically passive reflux of the esophageal contents into the mouth, which is not generally preceded by any retching or vomiting.
Yes.
And rumination is basically a persistent reflux of the contents, which generally ceases to act once the food contents become sour or bitter in mouth. And it is also generally not preceded by any retching or vomiting.
But let me tell you, Pius, you are talking about regurgitation. regurgitation can be gastric regurgitation, can be supragastric regurgitation. So gastric regurgitation means it is coming from the stomach. Like patient who has a very low ileus pressure. Now that fellow can regurgitate things from the stomach, which can be sour. Yes. So regurgitation can be gastric or supragastric. Supragastric is coming from the esophagus, ileus is closed. Gastric means coming from the stomach. The difference between regurgitation and vomiting is ask the patient what happens to the patient. Is it effortless or it is full of effort? What is effort? That means the fellow will tighten his abdominal muscle. Fellow will be running to the basin because he has nausea. So he has nausea. He's running to the basin. He's tightening the abdominal muscle. And also he is retching. Now this is vomiting. Okay, this is vomiting. Also remember one thing, many patients will say that, sir, I vomit 24 times a day. I tell you, more likely it is regurgitation. So then ask 24 times. That means what happened? He says, I'm moving around and I find my mouth is full of content and I spit it out. This is regurgitation. This is effortless. He did not go to the basin. He did not tighten the muscle. He did not retch. So retching, tightening of the abdominal muscle, alarm to go to the basin to put the vomitus out, and nausea are the feature of vomiting. Whereas in absence of all those is regurgitation. Now what is rumination? Rumination is if somebody regurgitates, be it supragastric or be it gastric, he swallows the content back. This is rumination. Normally in human, we don't ruminate, but the cows ruminate because cows have to take a lot of food, you know. So throughout the day, they will graze, put a lot of volume in their stomach because they are big size animal. Also, they have to take the most low calorie diet. And in the night when they are resting, they will ruminate. That means they will regurgitate, chew it and put it back into the stomach. That is rumination. So if anybody says, I regurgitate, but I don't throw it out. I don't throw it out. And then what will happen is then I take it back, maybe even after chewing is rumination. When somebody is regurgitating, just look at his throat. You can make out what he's doing. If the regurgitation is followed by throat activity, that means swallowing, this fellow is ruminating also.
Uday, just one more question, one more thing to clarify out here for residents, that say if somebody had dysphagia and rumination and regurgitation, does it rule out mechanical obstruction? So in mechanical obstruction, what is the status of regurgitation?
Govind, you brought out a very important question. I'll tell you why regurgitation occur. Regurgitation occur because the esophagus is full of content, the esophagus is dilated, and maybe upper esophageal sphincter has decompensated. Whenever the esophagus will accumulate food, now it will dilate, the upper esophageal sphincter pressure will go high to prevent aspiration into the lung. So that's why upper esophageal sphincter pressure will go up. But once the upper esophageal sphincter pressure cannot compensate anymore, they will have regurgitation. So because in achalasia, it is a disease of the esophageal wall and not necessarily of a narrowing in the ileus. It is a disease of esophageal wall. So achalasia patient have dilated esophagus along with an US decompensation. That's why they regurgitate more. But if you have a patient, let us say a peptic stricture, and that fellow is not treated for long, there is a possibility, or even a corrosive stricture of a short segment. Now, there is a possibility esophagus will dilate and they will regurgitate, but that hardly ever happens because if there is a mechanical narrowing, the fellow comes to the doctor quickly and the diagnosis is made also quickly by either barium or endoscopy and they are treated early. That's why they do not regurgitate so much. I hope I could clarify what you wanted to ask.
So, Uday, there is another question on the chat box by Dr. Amrit Gopan. Is rumination always followed by re-swallowing?
Sir, you are on mute.
Oh, that is by definition, because if somebody is not swallowing back, I'll say it is regurgitation. Why should I call it rumination?
Rumination. Absolutely right. Okay. So can we move on?
Yes, ma'am. Piyush, you can proceed with the examination.
Okay, sir. Now, in the general examination, patient was conscious, cooperative, oriented in time, place, and person, afebrile. The blood pressure of 118 by 80 mm of Hg, pulse rate 76 per minute regular, and respiratory rate of 16 per minute. BMI of 21 kg per meter square, and mid-arm circumference 21 centimeter, and without any features of muscle wasting. No parallel icterus, cyanosis, clubbing, lymphadenopathy, or edema. No thyroid swelling appreciable, and no signs of micronutrient deficiencies. Next slide. No features of any thickened skin, sclerodactyly, calcinosis, cutis, or telangiectasias. No skin lesions of dermatomyositis like Gordon's papules, heliotrope rash, V-neck sign, or shawl sign visible. Although desirable, we could not observe the patient to swallow in front of us. Next slide, please. Coming to the systemic examination, the per-abdominal examination was grossly normal, with the abdomen scaphoid in shape, umbilicus center, and all four quadrants moving equally. On palpation, it was soft, non-tender, without any organomegaly, and on percussion, liver span of 13 centimeter. Next slide, please. Cardiovascular system examination was within normal limits. On respiratory system examination, there were no creps or rhonchi. On neurological examination, both the sensory and motor system, including cranial nerve examination, was within normal limits.
So I think we can move on with the next section, since the examination was not contributory much.
Can I, Anshuman, can I ask a question to Piyush?
Sure, sir.
Piyush, you mentioned about telangiectasia in your general examination.
Yes,
What was the relevance of telangiectasia in a patient of dysphagia?
So actually, in cases of scleroderma, patients may have periungual telangiectasia. So that's why I specifically asked this.
Okay. And secondly, you mentioned about the neurological examination, the conscious, oriented to time, place, and person. So in a case of dysphagia, how relevant it is?
So any CNS tumors or CNS stroke can have patient with features contributing to those.
Very good.
Okay, I think Piyush, you can move on.
Yes.
So Dr. Gangadhar, I would request you to take over the investigations.
Good morning, all. Good morning.
So what investigation would you like to get done in such a patient first?
At this point of time, apart from routine investigations and chest X-ray, I would first go ahead with upper G endoscopy, mainly to rule out any mechanical obstruction and pseudoechalacia.
So Piyush, sorry Piyush, that is Gangadhar. You said chest X-ray.
Yes.
You said routine investigations and chest X-ray. How will chest X-ray help you here?
In
fact, we have a chest X-ray available. We'll put up the chest X-ray. Okay. Gangadhar, you can go on with your answer. So
now, why should Gangadhar interpret this? Those participants who are listening, can somebody put the answer in the chat box? That yes. What does this chest X-ray show?
So the audience are invited to put up their answers in the chat box.
So in the meantime, Gangadhar, don't give us the answer to this X-ray, but you can at least tell us what findings did you look for on this X-ray, given that you were shown a patient of dysphagia and regurgitation.
Yeah, but can we stop Gangadhar for a few seconds? Because, if he says, the people will pick up.
No, he will not give the diagnosis of this.
No, ma'am, even the findings
very good. Somebody said, somebody made out. Yeah, this is Kishore RVK. This is Dr. Kishore RVK. Absence of fundic gas shadow.
Yes.
Dilated esophagus. This is what
is dilated esophagus. Gangadhar, can you point out the dilated esophagus to us?
Dilated esophagus, I'm not able to appreciate much, but absence of gas fundus bubble, I can appreciate.
Okay. So actually, yeah, in this particular X-ray, we do not really appreciate a dilated esophagus very well. But you have to say right side of the chest typically may have a vertical line.
Yes.
And that is dilated esophagus. Maybe he imagined this line to be the dilated esophagus. Second is one can see a fluid level. In this patient, we can't see a fluid level. One can see a fluid level. And third is you must look at the lung film, because some of the achalasia patient may have changes in the lung because of the repeated micro or macro aspiration.
Yes.
Okay.
Yes.
So Uday, this was not related to achalasia. What I wanted to ask Gangadhar is that
Please.
in a patient who has come with dysphagia,
Yes.
what other findings will you look for, subtle findings which you look for on a plain X-ray chest? Just quickly enumerate them and move on to the next investigation.
Yes, apart from these, I'll also look for any pathologies in the lung. Sometimes cancer lung can present with dysphagia.
Yes. Then you can look for mediastinal lymphadenopathy.
Yes, mediastinal lymphomas also can present with something.
Because tuberculosis, mediastinal tuberculosis can sometimes.
It may give you a hint to the diagnosis. It may not be the cause of the dysphagia, but it may give you a hint to the diagnosis if you find a lot of mediastinal lymph nodes, or you find some lung tumors. That will just tell you a hint to the diagnosis. Okay, you can. I think we can allow him to move on. Uday?
Yeah,
Can I,
please.
Dr. Bhatia, can I add one point out here?
Yes.
That first thing that X-ray may not be the first test to do in patient with achalasia cardia. If
Okay.
available, certainly we'd like to see that. But since the point has come, say that always look at an organ which is proximal to a lumen.
Yes.
So in proximal to lumen of esophagus is lungs. So lung is at risk of any disease of esophagus if there's a micro and macro aspiration, as Dr. Ghosal said. It's very important to look at. Similarly, the bile duct stricture or bile duct stone, there's a liver in front of that. So liver get damaged. If there's a ureteric disease or stone or a stricture, the kidney get all the time. So it's always good to look at the proximal organ and effect of those luminal diseases on the proximal organ. So we should keep that in mind. Even in the brain, if the third ventricle is blocked, there will be damage to brain. So maybe keep all of these in back of the mind always.
Yes.
Okay.
Only thing is, Gangadhar, I have a question. You said you want to do upper GI endoscopy first.
Yes.
Now, do you really want that? Suppose if you do upper GI endoscopy first, what is the problem?
Sir, only to rule out any mechanical obstruction first.
But clinically, we never thought this patient as mechanical obstruction.
Yes.
I am asking what would be the problem if I do upper GI endoscopy first in this patient?
Sir, sometimes after upper GI endoscopy, there can be changes in the manometry at the lower esophageal junction.
Yeah, that's right.
No. So so I have a little correction to make, that in patients where you suspect achalasia and you have proof of achalasia by either imaging or a normal mucosa in the endoscopy, then it is fine to go ahead with manometry. But directly putting manometry as the first investigation before having any imaging or endoscopic evidence of a non-mechanical.
So what will you like to do first? Question is, you have endoscopy, you have barium. Maybe in achalasia, people will not do barium, they will do time barium esophagogram, and you have manometry. So manometry, endoscopy, time barium esophagogram, or barium. Now, which one will you
First
like?
upper GI endoscopy.
Okay.
Okay, carry on.
So
We
in fact,
have
we
a
have
point. Let us
Can
listen
I
to
ask
him
the
why he
question,
wants.
ma'am? Dr. Gangadhar, what important precaution will you take while subjecting this patient for upper GI endoscopy?
Okay, can be risk of aspiration. So, as these patients can have pooling of secretions and saliva. So, endoscopy that we can during endoscopy we can aspirate the fluid as long as we have seen the fluid, and before that we can even drain the fluid.
Anything else before doing an endoscopy? Because you know that the differential diagnosis is achalasia, and for a diagnosis you are doing an upper GI endoscopy. You know that there is a risk of aspiration. So what another important precaution will you take before subjecting this patient for an upper GI endoscopy?
So Piyush, no, sorry, Gangadhar, because his level is.
So will you put a Ralph's tube and aspirate the esophagus? This is what one of the participants has suggested.
Has written.
Yes, sir. Before procedure, we can do that.
So you can do that.
And secondly, rather, because most of us do an upper GI endoscopy with 6 hours fasting, 4 hours fasting. But in this patient, you will have to have a little prolonged fasting, maybe 12 hours, or so that you do not have much of the secretions which patient has taken a liquid diet or a swallow. So these are the two.
The other thing you can do is put the patient on a little head high when you start the endoscopy. And as soon as the scope reaches the esophagus, continuously aspirate and remove all the contents. So what Dr. Ajay Jain has given a very important pointer, that if you're suspecting achalasia, see that there is prolonged fasting, more than 12 hours, or you can ask the patient even to take a liquid diet for the previous 1 or 2 days. There is no harm in that. Otherwise, there will be solid food in the esophagus and be very difficult to proceed with the endoscopy.
Another thing is in a patient with intermittent dysphagia, in which one of the DD would be Jenker, be careful while you are passing through the nasopharynx, because if you go blindly and little roughly, you can enter into Jenker and perforate the Jenker.
Yes.
Very correct.
So
Okay,
go forward.
Go
forward.
So in fact, the patient underwent endoscopy. So Gangadhar, can you describe the findings?
Yes, sir. In the first image, there was some secretions, possibly saliva secretions were present. Otherwise, stomach, antrum, and duodenum was normal. And on retroflexion, fundus seems to be clear that there was no obvious any GE junction growth.
Okay, so can you appreciate the dilatation of the esophagus also?
Yes, sir. Esophagus slightly dilated, and I would also like to know whether there was any resistance while passing the scope through GE junction.
So in fact, the
Can
patient
you see
underwent.
from this image? Can you see from this image?
Can you see the LES properly in this image?
No, ma'am. GE junction was slightly.
There's a second image. There's a second image after this. Can you show it?
Even go to the report image.
You can go to
In the report, they
image.
have selected a good image.
The second one.
Yes.
See the second
Yeah,
picture
look at
there.
this.
What
Yes.
does that show?
So it was a rosette appearance, ma'am. Rosette appearance of the GE junction, or
And it looks also quite tightly closed. In a normal person, the LES, while doing endoscopy, opens up. Here it is not opening.
yes, sir.
Okay.
So somebody has asked this question, Atif Patel, any objective method to describe esophageal dilatation on endoscopy?
Endoscopy. So sometimes during achalasia, there can be change in axis of direction of endoscopy, ma'am, if there is a huge dilatation. But otherwise, objective methods and
There are very few objective methods. Secondly, the sensitivity of diagnosing dilatation at endoscopy is not very good. So,
So how will you know whether the esophagus is dilated or not?
so that is the question. Is there any objective method of describing esophageal dilatation at endoscopy?
No, but suppose if you say endoscopy is not good, Gangadhar, how will you know esophageal dilatation in every patient with motor dysphagia?
so you can go for barium, sir.
Ovarium. So can you show that next?
Sir,
If you have.
sir, in fact, we have the time varium solo. I would request Gangadhar to interpret. So this is the 1 minute film.
Yes, sir. One
This
and
is the 2 minute film. This is the 3 minute, and I have put them all together so you can interpret it now.
so these are the 3 spot on images of time varium, sir, at 1 minute, 2 minutes, and 5 minutes. And in the
But
first,
before that, we have to tell people how is time barium esophagogram done. Because maybe some centers still continue to do barium in a achalasia patient. One of the requests I will have is please convert barium, conventional barium to time barium esophagogram for your motor dysphagia patient, and then tell them how is time barium esophagogram done.
yes, sir. Sir, in time barium esophagogram, we'll use around 45% weight by volume of barium, and around 100 to 250 ml of barium will ask patient to swallow in around 10 to 15 seconds. Then at a consequent level, that is at 1 minute, 2 minutes, and 5 minutes, we'll take images. If at the end of 2 minutes, the entire barium has rushed from esophagus to stomach, then we can stop the procedure there, or else you can continue to the 5-minute level also.
No, so as you said, let me recapitulate. It should be a fixed density barium, which is 45% weight by volume. Second, a fixed amount barium. Fixed amount means you said 100 to 250 ml. It is in one patient, it has to be fixed. Like if I have given 100 ml one patient, now in the follow-up time barium is we have to give 100 ml again.
Yes.
So it should be a fixed volume per patient. If the esophagus is too dilated, you may give more, like instead of 100, 150, 200, but same patient should have the same volume of barium given. Patient should, the barium will be done obviously in erect posture. Patient should swallow the barium in one go. That means he cannot just keep on little bits swallowing and then waiting again swallowing. That is not the case. Swallowing has to be done in one go, and then you have to take the erect film in 1 minute, 2 minutes, and 5 minutes. Now, can you interpret?
Yes, sir. Sir, unlike in upper G endoscopy in barium.
1 second. Gangadhar, you want to be a bit slow. You go very rapid pace, so a bit slow. Look, one other thing, yes, volume, is your volume fixed? Means how do you fix the volume in a given patient?
Fixed because in time barium esophagogram, you not only do before treatment, you do after treatment to know the success of treatment. So that's why if you do, let us say 100 ml barium before, or maybe 200 ml barium before dilation or poem, and then you take 100 ml barium after poem, so then you will not be able to interpret the efficacy of the treatment. So it should be fixed per patient. So follow-up time barium should be done with the same one.
Yes.
So Govind, just another aspect to this. We try and tell our patients to take 200 ml, but many of these patients may not be able to swallow that much, which is why you let them take as much as they want and then write it down, and the next patient, and the next time they come, they take the same volume.
Yeah, that's it.
So the important message out here, which all of Gangadhar, Dr. Ghosal, and Dr. Bhatia is saying, that barium swallow is a great test, but if you could do time barium swallow is a more relevant, more important for diagnosis, not only for diagnosis, also for monitoring the treatment also. And please ask your radiologist. This is not a difficult thing to do. It's just about changing the attitude from doing a normal barium to a time barium. It's not difficult at all. It's just taking same thing, but probably in more organized way.
Yes.
So go forward.
Unlike in purge endoscopy, sir, but in barium we can objectively assess the dilatation of the esophagus, where the cutoff was around 3 centimeters width of the column. Here it was around 3.4 centimeters, so it was dilated. And while assessing the length of the barium column in the first image, so that is at 1 minute.
Can you show the pointer, please? Can you show the pointer?
Yes, sir. Sir, actually, while assessing the length of the barium column, we have to be very careful regarding this barium foam interface. Sir. Barium foam interface is nothing but it was at the top of the column. It was mainly due to the mixing of the barium and the pool secretions that should not be taken into consideration while considering the length of the barium column. So in the first minute, it was around 13 centimeters length and 3.4 centimeters width. So it was dilated esophagus, and I'm not able to appreciate any bird beaking appearance in the first image, but in the second image, slight bird beaking I can appreciate, sir. And even this barium column, almost the same column, around 12 to 13 centimeters, were persisting even at 5 minutes. So usually in most of the healthy individuals, the barium should go from the esophagus into stomach at the end of 1 minute. By end of 5 minutes, it should be in all individuals. So in this patient, there is a persistence of the barium column even at the 5 minutes and some sort of Barrett baking. So all these features are suggestive of achalasia cardia. So
okay, next.
So next, I would like to go ahead with gold standard for diagnosis achalasia cardia, which was high resolution manometry with impedance manometry.
So now you are talking about gold standard for the diagnosis, which is esophageal manometry.
Yes.
So can you show that?
Yes, sir. So the panel A shows a representative manometry from a normal person, and panel B is the manometry findings of the patient. So we have the these are the manometry. This is the manometry tracing of the patient in panel B, and here are the metrics.
Yes.
The inspiratory EGJ pressure was 79.4. The expiratory pressure was 59.7. The mean DCI was 542, and the IRP was 42.
Yes. So first, I would like to analyze the first image, sir, that is image A. In the extreme right of the image A, you can see the color coding, which was the blue with low pressure and almost pink and orange of high pressure, black of high pressure. So this was a high resolution manometry of a normal patient with 3 wet swallows, sir. We can see the 3 wet swallows and 2 striped bands. You can see the upper band was for upper esophageal sphincter and lower band for lower esophageal sphincter. And you can see 3 places where the upper esophagus started relaxation. And at the same time, you can see in the lower esophageal sphincter also started relaxation till the end of the contraction. This is nothing but the deglutition inhibition. So now if you can see the peristalsis of the esophagus initially started with the striated muscle, that was S1 segment, then followed by transition zone, then the smooth muscle S2 and S3 segments. So some of the important metrics in manometry we should know was, one was the distal contractile integral, that was the distal segment of the esophagus. The normal was around 450 to 5000. If it is less than 450, it was ineffective peristalsis, and more than 5000 hypercontractile contractions. Now, if you see the distance.
No, Gangadhar, here I will stop you. You know why? Yes. When you are trying to give the normal, yes, this is very important. So actually, if it is below 100 millimeter of mercury DCI, obviously, this is a failed peristalsis. Yes. Failed peristalsis. And above 8,000 is hypercontractile esophagus, above 8,000. So earlier in Chicago, earlier version, we said it is 5,000. Now we have changed to 8,000. 8,000. So you said 5,000, which is not correct. It should be 8,000. And below 100 is low. Now, when we classify achalasia, we classify further as type 1, type 2, and type 3. For that, we keep this breakup of 450. So below 100 DCI means type 1 achalasia. If more than 450 is the DCI, now if it is pan-esophageal pressurization like this patient, we call it as type 2 achalasia. If it is a segmental pressurization, we call it type 3 achalasia.
Yes. So now I'll explain the second one, sir, the patient's manometry, sir. In this patient's manometry, so while analyzing the manometry report, two things should be taken into consideration. One was the esophagogastric junction and one was the esophageal peristalsis. Now in the second image, if you can see the esophagogastric junction, it seems to be of type 1 because esophagogastric junction was made of mainly accrural fibers of the diaphragm and the lower esophageal sphincter, and there seems to be no separation between them. And there
so it seems to be, it is type 1.
It was type 1, sir. Yeah. And after the wet swallows, which we can see from the upper relaxation of the upper esophageal sphincter, and there was no corresponding relaxation in the GE junction. So there was incomplete relaxation in the GE junction. And after the starting the upper esophageal sphincter relaxation, you can see continuous contractions continuing from the upper esophageal sphincter through the body of the esophagus into the lower esophageal sphincter. These are the zones of pan-esophageal pressurization, which are characteristic of predominantly a type 2, although they can be present in type 3 also. So
no, type 3 will be segmental. This is not segmental.
Yes, sir.
This is pan-esophageal.
Yeah, okay.
Gangadhar, just a small correction. What you said is there was a beginning of contraction. There is really no contraction over here. There is actually, what has happened is that the esophagus is closed. Once the LES is not relaxing, the upper esophageal sphincter has closed after initiating the swallow. That means it is now there is what is called as a closed loop, similar to a closed loop. And therefore, the pressures that are there are similar across the spectrum, that is from the UES to the LES. And therefore, this is called pan-esophageal pressurization.
Yes.
So did you follow Gangadhar? This is also called mirror image.
Yes.
You see above the normal, you see this is not mirror image. whatever you are seeing, the contraction, there is a variation across the segment of the esophagus. Like the upper part, you see there is a weak contraction, then a very lower part, there is a very strong contraction. But here you see as if it looks like if you put this cut into half pieces of in this pressure profile, you'll see as if it is the image in the mirror. So as Dr. Sobna said, that if you take a pipe, let us say you take a tube, close the two ends of the tube, and now you press with your hand the tube, pressure across the tube will be the same because it is a closed loop or closed cavity. But now you open this tube in one end, you press above, that pressure in that area where you have pressed will be high, but the pressure below will be low because the content of the tube will go out. So it is a closed cavity phenomena. This is also called mirror image.
So Uday, just this thing, the mirror image terminology was used when we were using waves to analyze, because all the waves looked the same.
Yeah, that's right. But you can
that mirror image.
Yeah, so what Dr. Sobna said is right, but you can make a single click and convert this high resolution into a conventional manometry.
Yes, into a conventional manometry.
Yeah, that's right.
So
now, one more thing I wanted to tell you, there is a participant question. He is asking, can we calculate DCI when there is no peristalsis? Yes, you have to calculate. This is not for, DCI is not only for peristalsis, it is for any pressure activity. So that's why DCI called distal contractile integral. What is this? It is the amplitude of the contraction into duration of contraction. So DCI has to be calculated for even when there is no peristalsis. You are calculating the integral of the pressure wave of a contraction, and the DCI is important for classifying achalasia. Below 100 millimeter of mercury is type 1 achalasia. Between 100 to 450 millimeter of mercury is type 2 achalasia. If it is increased 450 millimeter of mercury everywhere in the esophagus, like in this patient, but if there is a segmental contraction, that is lower part is showing very high contraction, the upper part is not showing, or lower part is showing high pressure, upper part is not showing, this is called type 3.
So there is another question. Where do you put the contractile deceleration point in a patient who has pan-esophageal pressurization? So the usual thing is the contractile deceleration point is between 3 and 5 centimeters above the LES. You can put it there, but there is really, here you can see the whole thing is simultaneous. So the distal latency can be calculated from the beginning of the upper esophageal sphincter contraction to anywhere along this contraction, because this contraction is completely simultaneous.
Okay. So any other question from any participant before we move forward?
Dr. Uday, there is one question which we forgot while doing the barium, time barium. Is there any risk of aspiration of barium in these patients?
Yes.
You see, your concern is very valid, but fortunately aspiration doesn't happen. The reason is you are doing an erect posture. And obviously patient is deciding how much he wants to swallow. The radiologist is just noting down how much did he swallow for the next time barium esophageal that will be done in the future. Now somebody has asked, what is the significance of peristaltic break? You see, peristaltic break of less than 2 centimeters is normal. More than 5 centimeters is abnormal. Okay, so we have given a zone that is 2 to 5 centimeters as a borderline thing. Now, peristaltic break signifies, in normal individual, peristaltic break signifies that half of the muscles in this area is skeletal muscle and maybe about half is smooth muscle. And we all know the pattern of contraction of skeletal muscle. Skeletal muscle, the moment you stimulate it, there will be a rapid rise in the contraction, that is that there will be a rapid upstroke. Then quickly there will be a downstroke because skeletal muscle cannot remain contracted for long. They are typically type 1 twitch fiber. Now, in case of smooth muscle, we all know when you stimulate smooth muscle, it takes long time to go into a plateau phase. And then the plateau phase persists for some time compared to skeletal muscle. And then there is a downstroke. So what is happening in this part of the esophagus, that is upper part, because you have some skeletal muscle, some smooth muscle, and we know time duration of skeletal muscle contraction and smooth muscle contraction, the whole muscle bulk are not contracting together. Half of that muscle bulk is contracting where half has not arrived at plateau phase. Then the half is joining. By that time, skeletal muscle has done a downstroke. That's why you get a low amplitude, broad kind of contraction here. So this is peristaltic break. Now this is normal. If more than 5 centimeters wide is abnormal, because such a long peristaltic break is often associated with dysphagia.
So then other question, Uday, is any drug to be discontinued before performing HRM? Yes, any drugs that can cause decrease in LES pressure should be discontinued. And in patients who have asthma, also decrease their deriphyllin. They can take their inhalers because they don't directly impact the lower esophageal sphincter. And if the patient is on beta blockers also, you can try and stop it because they can sometimes increase LES pressure. Some patients are on nifedipine before they come for manometry because they've been given temporary relief of dysphagia. Nifedipine has been used. Tell them to discontinue these drugs before the HRM.
There is a question, is there a correlation between volume at 5-minute time barium esophagogram, LES pressure on manometry? Is a good question. I will tell you, time barium esophagogram is like echocardiography. You are looking at the ejection of the volume from the esophagus into the stomach. Like in echocardiography, they look at the amount of blood ejected through a valve. Whereas the manometry is a pressure. Obviously, it is not an electrical activity. Like in electrocardiography, you study the electrical activity of the heart. Now here we study the pressure, but this is obviously a derivative of electrical activity. So you can compare manometry with electrocardiography. The time barium esophagogram is with echocardiography. If there is a correlation, those people actually time barium esophagogram is measuring the esophageal emptying, whereas manometry is measuring the pressure. So they are totally different things, but there is a correlation. Those who have LES pressure high, they often don't empty the barium very well.
But there's one more thing, Uday. Probably this aspect should come after the treatment. But, you know, when the LES has been completely dilated, sometimes the esophageal motility is so bad, or that the esophageal muscle is so bad that it does not contract at all. In that case also, there will be a very delayed emptying of the esophagus on timed barium. But therefore, it is sometimes it does not correlate, and it may correlate prior to dilatation, but after dilatation, it only tells you that there is a delay in emptying.
Yeah, so that is very important. Let me tell you, we do not cure achalasia. If anybody claims that he cure achalasia, I politely and humbly say no. Be it in dilatation, be it poem, be it myotomy, we don't cure achalasia. We convert an achalasia patient into a scleroderma patient. So scleroderma patient, what do they have? Their body motility is poor because their muscles are all fibrotic. They have low LES pressure. In achalasia, before treatment, do we have? Their body motility is poor because of the muscle disease and neural disease, the esophageal neural disease. Their LES pressure is high. We just disrupt the LES and therefore we convert into scleroderma. So as Dr. Shobna said, the correlation is not 100%. Correlation may be 60 to 70%. Okay, so go forward.
So before we go to the management issues, we have a couple of poll questions coming up. So identify the primary esophageal motility disorder shown on the representative HRM tracing. So Dinesh ji, can you please run the poll? So let's see. We'll have the results available shortly.
Yeah, the primary.
So in fact, 60% of the people, around close to 60% of the people have got it correct. This pattern, although it represents hypercontractile esophagus, let me bring out a caveat here that the Chicago 4 says that you cannot diagnose a hypercontractile esophagus just based on the manometry tracing. You need clinical symptoms of dysphagia and or non-contractile chest pain, and this pattern should be at least in 20% of the swallows. So majority have got it correct, but there's a caveat to it. So we go on to the next poll question. What concentration of barium is used for a timed barium esophagogram? So Dinesh ji, can you please run the poll? So we had already, Dr. Gangadhar had already shown some light on this aspect. So
this was already answered in the discussion part while Professor Uday was discussing about
No, but that is very important. Still 5% say that this is 10%. It actually means there is a problem of online session. Some people might not be there in the session. Sorry.
That's no issue. Just one more point came that what is vigorous achalasia? Because in the last, we go back to last question and can you, one of you explain what could be vigorous achalasia?
You see, the earlier before this HRM did not come, we used to classify achalasia into two types: classic achalasia and vigorous achalasia. Classic achalasia meant that on conventional manometry, the average amplitude of contraction was more than 40 millimeter of mercury. That was less than 40 millimeter of mercury. That was classic. So if somebody had poor contractility of the esophagus, that means there is no contraction because muscles have all gone, then you do not have amplitude of contraction. So if it is below 40 millimeter of mercury, we used to call it classic achalasia cardia, which may be equivalent to type 1 achalasia according to Chicago classification. Whereas when the contraction amplitude was more than 40 millimeter of mercury, we used to call as vigorous achalasia, which according to current Chicago may mean type 2 or type 3 achalasia. So this is an old classification. We do not use it anymore.
So we'll come back to the question on timed barium esophagogram. So as Professor Makharia said, that it requires an effort on the part of radiologists and those requesting that we switch to timed barium esophagogram for evaluation of motility disorders rather than a barium swallow. So just to highlight that these are the concentrations of barium used for the various barium studies evaluating the esophagus. For a usual single contrast barium swallow, around 98 to 100% of barium is used. For a double contrast barium swallow, 250% is used. And for a timed barium swallow, 45% as discussed is used. So it is very important to remember these values, that it is not the same for all barium swallows. So apart from knowing about the investigations, we should also know what concentration of dye should be used.
And just to add on, you can see the reference below written by Dr. Uday and his team, how best to perform and interpret time barium. On JNM, this is a free journal, so you might like to refer to this article.
So we have the next poll question. This is just a trivia question, so don't get disheartened if you don't know the correct answer. Which of the following are not standard white light endoscopy findings of achalasia cardia? Rosette sign, pine stripe pattern, champagne glass, and ginkgo leaf appearance. So I think a quarter of participants for each of the options. So let's see the answer.
So it means your spin ball was too good. Nobody could play well.
Sir.
Yeah, it was all guesswork. Most of the people have done guesswork.
Yes.
So
the only thing that was shown, I think, during the endoscopy was the rosette sign.
yeah, yes, ma'am. In this patient, just the rosette sign was seen. So yes, this is just a trivia question which we have kept. So the answer is the pine stripe pattern. So all of us are aware of the rosette sign as was seen in the patient. At the lower end of the esophagus, you can very clearly see the folds emanating from the esophagogastric junction. The ginkgo leaf pattern refers to the pattern of the palisade vessels. Since the lower end of the palisade vessels is not visible, they appear to converge at a point, given the appearance of a ginkgo leaf. Similarly, champagne glass appearance refers to the pattern for achalasia patients seen in which due to contraction of the lower esophagus and high pressure, even before the squamo-columnar junction, the esophagus is closed. So you're not able to, at the lower end of the esophagus, when you insufflate, you're not able to visualize the squamo-columnar junction, and you are able to visualize the squamo-columnar junction on retroversion. So the appearance is like a champagne glass. So the pine stripe pattern is actually not seen on white light endoscopy. It is seen on image enhanced endoscopy or a chromoendoscopy. So there is wrinkling of the mucosa. You can see very clearly there is wrinkling of the mucosa here. So this sign was described recently. It is a sensitivity of around 60% for diagnosis of achalasia, but the exact reason why do these wrinkles appear is yet unknown. Whether it is due to the stasis esophagitis or a result of an increased pressure is still unknown. So this was just a trivia question. I think we can go to the management of the patient.
Can you go back? Can you go back to the question? So let everybody remember that. So you mean that pine stripe pattern is also seen in achalasia, but seen on
chromoendoscopy.
Chromoendoscopy. But otherwise, could we also say that what a ginkgo leaf sign?
So usually when doing a standard endoscopy in a normal patient, we are able to visualize the lower end of the palisade vessels while insufflating. But in achalasia patients, since the lower end is closed, the lower end of the palisade vessel seems to converge at a point, giving the appearance of a ginkgo leaf, the patterns on a ginkgo biloba leaf. So this is how the leaf appears. So the palisade vessels give a similar appearance. They seem to converge at a point, rather than we are not able to visualize the lower end.
Okay.
So we can proceed to the management of the patient. Dr. Gangadhar, you can take over, please.
Yes. So in this patient, I would like to explain here about the nature of the disease and the nature of the treatment that we are planning to give. It was mostly a palliative, not the cure. And then the type of treatment options available, and the efficacy, the safety, and the complications of the treatments, and also the durability of the treatments. So I would like to explain in this patient the first option of pneumatic dilatation, and followed by LS myotomy and the POEM also.
So what will be your first choice?
Yeah, what will you do?
So
you said everything.
Yes, sir. So I'd like to go ahead with pneumatic dilatation.
Give me some points. Why do you want to go with pneumatic dilatation while the entire world is fascinated by POEM and Haller's myotomy?
Yeah, now there are a lot of poets, so therefore POEM is being fascinated.
Sir, pneumatic dilatation is efficacious and almost equivalent to Haller's myotomy and the POEMs, both at the short term and in the long term, sir. But in the long term, patients might require multiple dilatations, and it was also almost a cost-effective treatment, cost-effective non-surgical treatment, sir, for the patient.
So tell me, what is the success rate of the first and pneumatic balloon dilatation? If you do a pneumatic balloon dilatation in this patient, what is the likely success in this patient?
Sir, after first, there was one study at our center, sir, almost around 126 patients of achalasia, where after first session of dilatation, almost around 75% of patients, that is close to 90% patients, have responded to first session of dilatation. Sir.
And if they do not respond to first dilatation, what will you do?
Ajay, can I just put in here?
Yeah, please.
What is your definition of first session of dilatation?
Ma'am, actually, both the American and European guidelines, they have said like first session of dilatation means initial dilatation followed after 2 to 4 weeks by repeated dilatation. So this is the first as per American and European guidelines. But in our center, sir, ma'am, we have done in this study of 126 patients of follow-up of 1 decade. So we have seen many of the patients, almost close to 75% have responded after 1 session of dilatation. But remaining out of 126 patients, close to 115 patients, that was 90% of the patients have responded after 2 to 3 dilatations.
So that means many patients do require more than 1 dilatation.
Yes.
You can call it a session, or the first dilatation is something that where you do one dilatation and you repeat it after 2 to 3 weeks. That is also considered as one session of dilatation.
Yes.
So considering that, yes, the success of pneumatic dilatation is very high, but the groups which do POEM or the surgeons would really feel that POEM as well as Heller myotomy have better success rates than your 75%.
Close to around 95% POEM have a success rate.
What I'm saying is, as Dr. Sobna said, see what happens is because pneumatic dilation is simple, is very cheap,
Yes.
practically non-surgical, practical, because you are going through the mouth with an endoscope and dilating inside, you are not making any hole anywhere. So cheap, widely available. So question is number of people doing surgery or POEM would be maybe less in expert center particularly than those doing pneumatic dilation. So cheap, widely available, quite safe, efficacious. This would be the first option of treatment. There could be exceptions, like type 3 achalasia don't respond well to pneumatic dilation. So there is a question, should we do dilation in a patient with type 3 achalasia? Yes, I agree. Second is very young patient. Let us say a fellow is 25-year-old. We all know the dilation is not as effective in young compared to the old. Particularly male young, they have less efficacy than female young patient. So there is an option for the patient to directly go for POEM or surgery if young patient, particularly male and type 3 achalasia. Otherwise, since the pneumatic dilation is easy, you do that. If the fellow does not respond, then there are other choices. The choices are POEM or Heller's myotomy. So these two are quite good options. But remember one thing, that POEM is often associated with reflux esophagitis in a very high frequency. So to the extent of 40 to 50% after POEM will develop pathological reflux. So that you have to take into consideration while you say POEM as a very great option.
Can I request Professor Uday, Professor Shobna, because we should concentrate on our the next 10 minutes or so on pneumatic balloon dilatation, because that is mostly available, and we should less often discuss about POEM and Heller's in this particular 10-15 minutes session.
So the question to you, Gangadhar, is how do you dilate and what are the variations that people use during their dilatation? Which balloon do you use?
Actually, most commonly used was a 30 mm balloon, but in certain...
No, what is the name of the balloon?
Sir, low compliance Rigiflex balloon, sir.
It's a Rigiflex. So previously we used to have the Brown-McHardy dilator, and which was a very good compliant balloon. So this low resistance balloon, as you called it. So how much pressure, how much time, and what are the variations that people use?
Yes, so most commonly used balloon was the 30 mm balloon, ma'am. But in one subset of...
But let me, Gangadhar, tell this. See, you use a Rigiflex dilator. Rigiflex dilator is available in 3 sizes: 30 millimeter balloon, 35 millimeter balloon, and 40 millimeter balloon. Earlier convention was you do a graded dilation, start with 30 millimeter balloon, go to 35 if there is non-response, then go to 40. But there were 2 studies published in around 2004 or 5. One was from our center, published in American Journal of Gastroenterology, where we found that if you use 30 millimeter balloon in a male patient, response was not good.
Yes.
Another study by Michael Veggie's group, which was published in Clinical Gastroenterology and Hepatology in the same year, they found the similar situation. If you use 30 millimeter balloon in a male patient, the response was not good. And this is expected because male are supposed to have stronger muscle, both skeletal muscle as well as smooth muscle, than female. So therefore, now we switched, and many people have switched. that if you are dilating a male patient, use 35mm balloon in the first go. If you are dilating a female patient, use 30mm balloon in the first go. Now, how to dilate? Most people will say do under fluoroscopy. So what happens is that you put the patient on the table, put the dilator over the guide wire, which is guided through the endoscope, and then place it in the G junction, put a contrast inside the balloon, and then put pressure, and then see the waste, because if the balloon is being filled up, now there will be a waste at the region of LES. So there will be an indentation at the region of LES, and you want to put that much pressure, which will lead to disappearance of the waste. So this is the standard method. But I tell you that maybe because of the necessity is the mother of invention. So what happened is in our center, we had difficulty in dilating because we had one fluoroscopy machine, and that was always occupied by years in ERCP. So therefore, we started doing without fluoroscopy. So how do you do without fluoroscopy? You put the endoscope into the stomach, pass a guide wire, like a zebra guide wire or any other similar guide wire, into the stomach. Take out the scope. Over the guide wire, you thread the balloon. Take the whole balloon into the stomach while you have put the endoscope by the side of the balloon or the guide wire, and then pull the balloon back to place it in the G junction, so that half of the balloon will be in the stomach, half of the balloon will be in the esophagus. And then you dilate, typically used to 5 to 6 psi. PSI is pound per square inch. So you use 5 to 6 psi pressure to dilate, distend the balloon, and keep it for about 1 minute. Now, while your endoscope is by the side, and you can see your balloon is getting beautifully inflated, and it has become oval because it is an oblong or a long balloon. Now, if you see it oval structure, means half must be in the stomach. Now, what you have to do is that after you have dilated, efficacy of the dilation you can assess by blood over the balloon, the mucosal tear, and the size of the cardia after you have dilated. Remember one more thing, that you can have perforation. The perforation frequency is about 3 to 4%. So if you dilate 100 patients of achalasia, 3 to 4 would perforate. Luckily, our perforation rate is much lower. It is about less than 1%. One of the reasons is we do not sedate the patient too much. Because if you sedate and do a very bookish job, you have a higher rate of perforation. So we give a very light sedation so that depending upon the pain of the patient, we decide duration of inflation and the pressure. Now, what happens is that the perforation, I told you, if you ask the patient, when was the maximum pain? Was it when I was inflating the balloon, or was it after I completed the procedure? If the patient says pain is increasing even after completing the procedure, you have perforated. Now you have perforated because air is now leaking and dissecting between the layers of mediastinum. So this patient, you do a CT scan, you may find pneumomediastinum, but most patients you can manage conservatively until there is a free leak. We now even use a covered metal stent to treat some of our perforations. So if there are any more questions, I can answer. This is the method without fluoroscopy has also been described very well by Dr. Ramesh Ruprai's center. And in fact, there is a publication in GI endoscopy, dilation without fluoroscopy, and we have published dilation without fluoroscopy.
Just 1 second, just for information, that PSI to millimeter of mercury, because we are used to know, our minds thinks about millimeter of mercury as we take blood pressure. So 1 PSI is about 51 millimeter of mercury, or you can remember 50 millimeter of mercury. 1 PSI is equal to 51 millimeter of mercury. So about 8 PSI is about 400 millimeter of mercury. So you understand how much pressure you apply to esophagus. So our blood pressure is 120, 140 or so, but here we put it is 400 millimeter of mercury. I think in interest of time, do you want to
So,
Go
for
forward.
instance, I just add a few things. I'll just add quickly a few things. One is what Uday described, the complete detailed procedure. See, the standard is under fluoroscopy. And for people who have not seen it being done without fluoroscopy, please do not attempt it without fluoroscopy. Otherwise, there can be problems. You can perforate. The second is that the PSI that we use, quite often it varies. There are people who would go directly to 10 PSI, but dilate only for 10 seconds and say that their dilatation is adequate. There are others who will go with lower PSI. For example, I myself am err on the side of safety and therefore would not allow a full dilatation at the first instance. I wait for about 2 minutes and do a second dilatation in the same sitting. While the balloon is still inside, I deflate the balloon, wait for 2 minutes, and then dilate again. So that what happens is, if the first time, if you dilate it very rapidly, you can actually cause a perforation. But if you wait for some time and you've already partially dilated, you can move to full dilatation in the second or even the third instance at the same session. Gives better results, is again unpublished data. The third is the timing. Some people say 10 seconds, 15 seconds. Some people say it should be for at least a minute. And there are various studies to prove that. The third one was when do you do check for the perforation? Now, at some centers, they immediately give the contrast as soon as the dilatation is done to check whether there is some degree of perforation. But that is really not the way to do it. What we can do is we can wait for an hour or so, watch the patient for development of pain or tachycardia. And if there is any evidence of any complication, we would come to know. So that is the thing on balloon dilatation. Next.
Regarding use of balloon, 35 balloon at first session. So whether any risk of increase in perforation by using 35 balloon? Because
No,
so that is only, so that is only if it is a thin woman, you would go in with 30 first, otherwise 35 is standard. Now there was a very large randomized trial of studying surgery versus balloon dilatation, where the first part was done with the 40 millimeter balloon, and they abandoned that because there were a lot of perforations with the 40 millimeter balloon. So 40 millimeter balloon is very, very rarely used.
Yeah, that is what Dr. Sobna is referring to, that NEGM paper.
NEGM
very
paper,
interesting
yes.
paper.
Very
Almost 16% perforation rate initially. Absolutely unacceptable. I don't know how did they do that. Now,
Yes.
question is, now there is a question. Question is, So what is the preferred treatment? What is the preferred treatment of achalasia? If somebody asks, what is the preferred treatment of achalasia? Maybe somebody is worried for his exam and he is asking us. So preferred treatment of achalasia, first line is pneumatic dilation. If they want reference, I tell you, we published expert consensus on achalasia in Journal of Gastroenterology Hepatology, in which most of the poem people were also involved, including AIG. The consensus was made by AIG. But still, experts agree that pneumatic dilation is the first treatment, except in type 3 achalasia. So don't be worried.
Govind, just a minute. Before we go in, because it's already 1:20, there are a couple of things which I would like to add, Dr. Gangadhar and Piyush and all the students. You should be mentally prepared to manage complications after a pneumatic balloon dilatation. So one of the things which was discussed by Dr. Uday was covered esophageal stent. But nowadays you can also use hemopreps as well as the over-the-scope clip. So you should be mentally prepared how to manage the perforation, which is because most of the perforation are minor perforation, can be managed and without any intervention by putting a Ral's tube and a needle by mouth. But in case you require, you can do that. Yes, Dr. Govind.
No, I just wanted to emphasize that only that they said that the Indian guidelines, but also the guidelines which are the American guidelines. They also say that for type 1 and we have all three options available: pneumatic, POEM, or surgery. All have equal efficacy, but depending upon availability, you can choose pneumatic. Pneumatic is freely available at all centers, and this has a good efficacy in terms of its response. Yes.
Dr. Govind, can I take this liberty because already it is 1:20? Can I invite Professor Shobna to make a concluding remark in this particular patient? Professor Shobna.
I
Just
have
follow.
But before that, Gangadhar, in 30 seconds, can you show the repeat manometry?
Yes.
What happened to the, just
So
show
this
this.
is the
Yes.
follow-up of the patient.
So this is the follow-up of the patient. Sir, ECA was 2, so less than 3 we can consider as a success, clinical success. And the repeat manometry was showing decreased esophagogastric junction pressures are around 31, and IRP was also 11, less than 15. So this patient, you can say it even on the manometry also it was a.
Okay, so we complete here and then let the Dr. Shobna give the concluding remark.
So just show the previous slide one more, Gangadhar, the last one of the manometry. It is just to tell you that the system that you've used in is slightly different, and therefore the color codes are different. So whoever is looking at manometry, please look at the colors on the right. Piyush mentioned it when he was looking at the manometry, that always look at the colors on the right before deciding what color matches what pressure on the graph. That's very important. Okay, yes. So can I have my slides or they are...
Gangadhar, stop sharing.
Yes.
So can I have my slides or should I share from my this thing screen?
So Dinesh ji, if you have ma'am's slide, you can share. Otherwise, ma'am can share from her side.
No, let us share the screen. Let us share.
Okay, ma'am.
You can share, ma'am. You can share the screen.
Should I share it? I have no problem.
Yeah,
no, please do. Unless you have difficulty for your laptop or iPad.
No, so I'll just, no, I'm on my Mac. So there is no problem here. So what I'm going to do is just in a nutshell, go through esophageal dysphagia. I have one slide on overall dysphagia, but that will take time. So therefore, I'm going to just go through esophageal dysphagia. If a patient comes with suspected esophageal dysphagia, this is something that we didn't discuss, so therefore I'm putting it up. Always ask for a history of prior radiation, caustic injury, surgery for laryngeal or esophageal cancer and a complex stricture. In a person who comes with acute dysphagia, also ask for medications like doxycycline and painkillers because you might actually have missed a pill esophagitis. If there is such a history where you suspect that there is a stricture, then in some cases, you may actually do a barium swallow first. Otherwise, you can directly go on for the endoscopy. If the patient has a history of, say, allergies, previous asthma in childhood, and food impaction, this is something, again, that we didn't discuss. If there is food impaction, then in that case, even if the upper GI endoscopy looks normal mucosa, take esophageal biopsies to rule out eosinophilic esophagitis. Again, on endoscopy, if you find structural abnormalities like ring, web, strictures, erosive esophagitis, or a tumor, of course, you will take these biopsies in these. But if the upper GI is normal and the dysphagia is to solids alone, then you can go back and do a barium. If you're suspecting a motility disorder, then in that case, it is esophageal manometry. But sometimes when there is dysphagia to solids alone, a soft stricture like a Schatzki's ring may be missed on an endoscopy because our endoscopes are thin, soft strictures may be missed, and you can actually see these webs or extrinsic compressions which are better picked up on a good barium done properly by your radiologist. If all these are normal, you will go to manometry, which we've already discussed in detail. And if there are equivocal results and you still have not done a barium, then go back and do a barium. The important advance that has happened in manometry now is the addition of impedance. I'm not adding that in this slide because that's a completely new topic. And these days, impedance is used also to replace the timed barium because you can check the levels of the fluid after a swallow. You can try giving 150 to 200 ml of fluid and check the levels on the impedance, and you should be able to get whether the patient continues to have obstruction after a dilatation of achalasia. And that's where I'm closing off in the interest of time. Thank you, Govind, for allowing me to give this algorithm.
Any last minute comment? Maybe stop sharing screen, ma'am.
Yes, that's what I'm doing. Yeah. Okay.
My only comment is that because both the candidates were from Professor Ghoshal Center, so they were very comfortable with motility disorder of esophagus.
Yes.
They have done a wonderful job. It was a very good history and a very good discussion. So, and I request all the students that they should know now how to read the manometry, because this will be asked in the exam. Whether your center is doing it or not, it is immaterial, but you should know how to interpret the manometry, simple manometry findings in the interest of your exams.
Not only the residents from SGPJ, but again, the qualitative question we have from other participants, that's also remarkable that very smart questions were put into chat box, and most of which all of you could respond to. Any last comment from the Ghoshal, and then before we close, have some comments to make.
Oh, thank you, Govind. Because of interest of time, I will not put more comment, but I think it was a good session, and I hope that people have enjoyed the session. I thank Dr. Govind, Dr. Piyush, Dr. Gangadhar, and Dr. Jain, Dr. Ansuman for making this successful.
Thank you so very much, everyone, for joining for this session. I think also we want to thank all the faculty members, Dr. Documentation, as Dr. Jain said, that you both of you have been extraordinary in the case presentation. The poll questions created by Dr. Ansuman was remarkable. A lot of learning point came through those. So with this, we close today's session, and we invite you to join one another masterclass next week, that is on October 24, on some other topic. With this, we can log off. This is lunchtime. Thank you so very much, everyone. Thank you, Dinesh. Thank you, Vikas. Thank you, everyone, for joining this session. See you on October 24 at 11:30 in the morning time. Okay, bye-bye.
Thank you, Govind. Bye.
Thank you.
Thank you.
Thank you. Bye. Thank you.
Thank you.
Bye. Thank you. Thank you, everybody, for joining.